Have you ever stood in front of your bathroom mirror, maybe leaned in a little too close, and just stared at a stubborn acne scar or like a really deep fine line?
Oh, yeah, we all do that.
Right. And you look at it and you wonder, what it would actually take to just erase it, to completely wipe the slate clean? Because we live in this era where achieving what we consider perfect skin often means, well, we have to go to war with it first.
A highly calculated microscopic war, really. I mean, the biological key to dramatic rejuvenation is controlled damage. You are essentially tricking the body into a state of panic healing.
Which is wild to think about. So today, we're doing a deep dive to demystify exactly what it takes to erase those marks. We've got a huge stack of sources for this, ranging from NHS clinical guidelines and the American Board of Cosmetic Surgery to deep clinical studies of like 500 patients and specific dermatological case reports.
It's a lot of ground to cover.
It is. The mission today is to explore the actual mechanics of acne surgery and laser resurfacing, that intense, ugly duckling recovery phase, and why the medical consensus on who is actually at risk for complications is completely changing.
Right. But before we get to the lasers vaporizing tissue, we really need to talk about the physical terrain they are treating, because scars aren't just one uniform blemish.
Yeah, they're not all the same.
Exactly. When a dermatologist looks at an acne-scarred face under those bright clinical lights, they're categorizing a really varied landscape. They are mapping out the architecture of the damage.
And from the Indian Journal of Dermatology guidelines we looked at, they broadly break this down into a few types. You've got macular scars, which are flat and either hyperpigmented or erythematous, so red.
Right, flat color changes.
And then you have the elevated ones, the hypertrophic or keloidal scars,
Yeah.
which are those fibrotic bumps you often see along the jawline.
Yeah, but the heavy architectural work, the procedures that require intense mechanical intervention, those are for the depressed scars. And these fall into three distinct structural categories.
Okay, lay those out for us.
So first you have rolling scars, which are distensible with gentle sloping edges. Then boxcar scars, which look like tiny punched-out craters that are wide at the surface and the base. And finally, the ice pick scars.
Ugh, the dreaded ice pick scars, deep, sharp, narrow. It literally looks as if the skin was punctured by a tiny tool.
That's exactly right. And here is where the mechanical warfare begins. Because, well, you can't just run a laser over a deep tethered cavern and expect the surface to magically look flat.
Right, that wouldn't make any sense physically.
No, it wouldn't. So for those rolling scars, they do a procedure called subcision before lasers even enter the room. Subcision is this fascinating mechanical release.
How does that work physically?
The physician inserts a specialized blade, often a no-core needle, deep into the dermis adjacent to the scar. And they fan it back and forth, physically slicing through the fibrotic strands of tissue that are pulling the surface of the skin downward.
I was picturing this like a hot air balloon that's been tied to the ground.
Oh, I like that.
Yes, the surface of the scar is the balloon, and those tough fibrotic strands are the anchor ropes tethering it deep into the tissue. So sweeping that needle is cutting the anchor ropes so the skin can finally float back up to its natural elevation.
That visual captures the physics perfectly. You release the physical tension to smooth the surface. But subcision doesn't work for ice pick scars because the architecture is just too narrow and deep.
So what do you do for the deep ones then?
For those, they use punch excision. They literally take a tiny biopsy punch, core the scar out entirely, and stitch the microscopic hole closed.
Wait, really? They just core it out?
Yeah, you are trading a deep, untreatable pit for a flat, treatable surgical line.
Which makes logical sense, I guess. But the most terrifying pre-laser mechanical technique we looked at has to be TCA cross, the chemical reconstruction of skin scars.
Oh, yeah, that one is intense.
Extremely. They take 95% trichloroacetic acid. 95%. They dip a wooden toothpick into this extraordinarily potent acid, place it directly into the base of the ice pick scar, and press down into the floor of the wound for a full minute.
Which sounds brutal, but you are inducing immediate, highly localized necrosis.
So you're intentionally killing the tissue.
Exactly. By killing the tissue solely at the deepest floor of the scar, you force the body's wound healing response to focus all its energy at the very bottom.
Oh, wow.
Over the following weeks, new collagen forms at that base, and the floor of the scar literally heals upwards. It raises the depth of the hole until it sits flush with the surrounding skin.
So we are slicing anchors, coring out tissue, and dropping 95% acid into the face just to prep the terrain. It really frames how aggressive this field is.
It's microscopic demolition.
Truly. But once those deep structural voids are leveled out, the focus shifts to resurfacing the entire landscape, which brings us to the heavy artillery, the CO2 laser.
The carbon dioxide laser remains the absolute gold standard for profound resurfacing. It emits a wavelength of light at exactly 10,600 nanometers.
And 10,600 nanometers is a highly specific frequency. I assume that's targeting something very specific in the tissue itself.
It's targeting water. At that exact wavelength, the light energy is almost exclusively absorbed by H2O.
And since human tissue is, what, mostly water anyway?
Right, so when that laser hits, the water inside the cells absorbs the energy and vaporizes instantly. The cell simply ceases to exist.
Boom. The tissue is just gone.
Yeah.
Which brings us to the distinction between ablative and non-ablative lasers.
Let's break that down.
Yeah, so the CO2 is ablative because it physically destroys that outer layer, the epidermis, while driving intense heat into the underlying dermis.
And that heat is the catalyst. It forces the old, disorganized collagen fibers to shrink immediately, while triggering a massive long-term production of new collagen and elastin.
Whereas a non-ablative laser is gentler.
Yes. A non-ablative laser, like an AIR-RA or intense pulse light, leaves the surface completely intact and only heats the deeper tissues.
Okay, and then within the ablative CO2 category, you have fractional versus non-fractional, which is also called full field delivery.
Right. Fractional breaks the laser beam into a grid. It vaporizes tiny microscopic columns of tissue while leaving a grid of healthy, untouched skin in between those columns.
And that healthy skin acts as a bridge to help the face heal faster.
Right, exactly. Non-fractional means the laser removes 100% of the surface layer, total vaporization.
So looking at the sheer trauma involved, if the recovery from a non-fractional fully ablative laser is incredibly brutal, why would anyone subject themselves to that over the gentler fractional methods?
Well, the decision rests entirely on the trade-off between downtime and dramatic, singular results.
Meaning one session versus many.
Exactly. Fractional lasers generally require 3 to 4 sessions spread over several months, and the outcome is inherently more subtle. A non-fractional, fully ablative pass offers a profound erasure of decades of sun damage, deep wrinkles, and severe acne scarring in a single afternoon.
So you endure a savage recovery in exchange for a total, undeniable reset of the skin's surface.
That's the deal you make.
And the sensory experience on the day of the procedure really reflects that severity. Imagine you are lying in the chair with thick numbing cream applied. Sometimes you're under mild sedation.
They place solid protective metal shields under your eyelids to protect your corneas.
Which is terrifying. And then, for 20 to 30 minutes, the handpiece methodically tracks across your face. You feel this intense, warm tingling, and you hear a continuous, soft, snapping sound.
And that snapping in the water in your cells literally vaporizing into the air.
It's crazy, but the procedure itself is relatively brief. The commitment to the aftermath, though, is monumental. The clinical intervention is just the spark.
Right. The actual rejuvenation and, honestly, the highest risk of permanent damage happens in the patient's own home over the following weeks.
The crucible of recovery. Let's talk about those first 10 days, because vaporizing the surface layer means you've just stripped away the body's primary shield.
You're completely exposed.
Yeah, you leave the clinic, and suddenly you enter this intense phase where the skin is defenseless. Immediately, you experience severe swelling and what clinicians call pinpoint oozing.
That oozing is serum. It's the natural biological response to a severe burn. The body rushes plasma to the surface to protect the raw, exposed tissue and flush away any debris.
You also develop this bronzed appearance as the vaporized layer dries up and begins to shed, alongside tiny white dots everywhere the laser hit, which eventually turn brown before flaking off.
It's affectionately called the ugly duckling phase.
Very appropriately named. And this is where I find the medical protocols utterly fascinating. The official aftercare instructions from major hospital systems like Queen Victoria Hospital are incredibly rigid.
Very rigid.
You are dabbing the skin with cleansing cream, never rubbing. You sleep propped up on 2 to 3 pillows to fight the swelling. Absolutely no sweaty exercise for a full 2 weeks. But the cornerstone of the recovery is maintaining a continuous, thick, occlusive barrier of Vaseline.
The absolute priority is preventing the skin from crusting over or forming a scab.
But I have to push back on this a little, because we just used a $1 million 10,600 nanometer laser to vaporize microscopic columns of human tissue, and the gold standard medical aftercare is Vaseline and a DIY white vinegar wash.
I know, it sounds too simple.
Why not a sophisticated medical-grade healing cream packed with growth factors?
Because applying complex active ingredients to an ablated surface is incredibly dangerous. When the barrier is gone, your skin has zero defense mechanism.
So it just absorbs everything.
Right, and fancy healing creams almost always contain preservatives, botanical extracts, or fragrances. On raw tissue, those ingredients act as severe irritants, often triggering massive allergic reactions or contact dermatitis.
That makes sense.
Vaseline is completely inert. It doesn't interact with the biology at all. It simply sits on the surface, creating a sterile, moist environment. This moisture allows the new epithelial cells to physically slide across the surface and close the wound.
Oh, so they need to move.
Yes. If you let the wound dry and a scab forms, those new cells have to burrow deep underneath the scab, which invariably leads to scarring.
The mechanical action of the cells needing to literally slide across the face makes perfect sense. And the vinegar wash. The protocol specifically calls for 2 caps of white vinegar diluted in 2 liters of water.
White vinegar is dilute acetic acid. It functions as a gentle, highly effective, non-irritating antimicrobial agent.
So it's just keeping it clean.
Exactly. It specifically prevents Pseudomonas bacteria from colonizing the raw skin without the toxicity of harsh chemical cleansers.
It is brilliant in its simplicity. But navigating this vulnerable state brings us to the very real complications. When researchers analyzed data from 500 patients undergoing this procedure back in 1998, the statistics were sobering.
They really highlight the risks.
100% of the patients experienced postoperative erythema, intense redness. And we aren't talking about a weekend of looking flushed. The average duration of this severe redness was 4.5 months.
The psychological endurance required for this recovery cannot be overstated.
It's immense. Imagine you're going to the grocery store, attending meetings, seeing family, looking like you have a severe weeping sunburn for almost half a year.
It's a huge commitment.
The disparity between a 30-minute procedure and a 4-month social recovery is a massive filter for who actually goes through with this. And the complications go beyond just redness. 10 to 15% of patients develop acne flares, severe dermatitis, or milia.
Milia are those tiny, hard white bumps trapped under the skin.
Right, I've seen those.
Because the laser triggers such rapid, panic-induced healing, the new surface often seals itself too quickly, trapping keratin and dead cells underneath before they can naturally exfoliate.
There is also a 7.4% risk of herpes simplex virus reactivation, which forces almost every patient to take prophylactic antiviral medication. I imagine that's not just a coincidence of timing.
Definitely not. The virus lays dormant in the nerve ganglia. The sheer thermal trauma of the CO2 laser sends shockwaves of heat and inflammation down those nerve pathways, which essentially wakes the virus up.
Wow, just the heat alone triggers it.
Yeah. Without antivirals, a cold sore on a fully ablated face can spread rapidly and cause devastating scarring.
The warnings get even more severe around the eyes. If they laser the periorbital area and the skin tightens too aggressively as it heals and shrinks, it can cause ectropion from the Mayo Clinic warnings.
That's where the lower eyelid physically turns outward, exposing the inner eye, which requires surgical correction.
But the most persistent hurdle, the complication that has historically gatekept this procedure from a huge portion of the global population, is post-inflammatory hyperpigmentation, or PIH.
Right, the skin darkening. In that same 500-patient data set, 37% developed PIH. The skin darkened dramatically after the trauma.
And historically, this risk was overwhelmingly skewed toward patients with darker skin, specifically Fitzpatrick skin types 4 through 6. For decades, the standard advice from institutions was a hard contraindication if you have brown or black skin. Ablative CO2 lasers are too dangerous because the thermal trauma guarantees hyperpigmentation.
That was the accepted truth for a long time.
But we found a glaring contradiction in the current clinical literature. A massive 2023 review by Binduck al. noted that in their analyzed studies, the Fitzpatrick skin phenotype didn't actually seem to influence the PIH risk.
It's a massive shift in understanding.
How can melanin both be the primary problem in the 90s data and suddenly not be the determining factor in 2023? What changed?
The physics of how we deliver the light changed.
Oh, really?
Yeah. PIH is not simply triggered by melanin reacting to a flash of light. PIH is fundamentally driven by inflammation.
Okay.
In the older lasers, the primary cause of this inflammation was bulk tissue heating. The laser fired sequentially, dot by dot, right next to each other.
So the heat just builds up.
Exactly. The heat accumulated in the tissue faster than it could dissipate. That bulk heat triggered a massive inflammatory response, and that localized panic signaled the melanocytes to dump pigment.
Oh. So if you eliminate the bulk heat, you eliminate the massive inflammation, and you protect the melanocytes from overreacting, regardless of the patient's baseline skin color.
Which completely shifts the paradigm. When dermatologists began testing new delivery methods on patients with darker skin tones, specifically in a major 2015 study out of Vietnam, they achieved something previously thought impossible.
Zero hyperpigmentation.
Zero.
And they achieve that 0% rate using what's called a Z-shaped pattern scanning algorithm. Instead of placing the microscopic laser dots in a neat little row, the computer makes the laser jump around the treatment area in a Z shape.
It completely changes the thermal dynamics.
I think of it like managing the temperature in a swimming pool with a bucket of extremely hot coals.
Okay, I can picture that.
If you drop all the hot coals into one single corner of the pool, the water in that corner boils instantly. The heat accumulates. Right. But if you drop one coal in the deep end, then immediately walk over and drop one in the shallow end, then one on the far left side, the overall temperature of the pool stays cool.
That is a brilliant analogy. The algorithm maximizes the physical distance and the thermal relaxation time between adjacent laser spots. It gives the tissue microscopic fractions of a second to cool down before the area next to it is impacted.
Which is such a simple engineering fix when you think about it.
But they also paired this mechanical algorithm with extreme visual precision. The physicians utilized 2.5x magnifying loops to continuously assess the depth of the ablation, achieving a perfectly uniform 0.05 millimeter thermal injury.
So they are literally watching the skin cook at a microscopic level.
Exactly. It's a level of strict checkpoint control that simply didn't exist in previous decades.
And alongside the mechanical engineering, there are fascinating pharmacological solutions emerging to suppress that inflammation. The 2023 review highlights that applying a very strong topical steroid, clobetasol propionate, lowered the incidence of PIH significantly.
It suppresses the immune panic.
Yeah, even applying fusidic acid cream, which is technically an antibiotic, lowered the PIH rate to around 53%. It proves that if you aggressively chemically suppress the panic healing response in the tissue, you protect the pigment cells from going into overdrive.
You manage the biology from both a mechanical and a chemical front. However, there is one biological checkpoint where this entire process completely fails.
The ultimate medical red flag.
An absolute red flag where dermatologists will refuse to touch you with a laser, and it involves a common acne medication called isotretinoin, widely known as Roaccutane.
Ah, right. The systemic retinoid used for severe cystic acne. It works miracles for clearing breakouts, but the mechanism of how it works makes your skin completely incompatible with laser trauma.
Isotretinoin works by radically shrinking the sebaceous glands and halting keratin production. The critical issue here is that your sebaceous glands, your oil glands, and your hair follicles serve as the hidden reservoirs of stem cells.
Oh, I didn't know that.
Yeah, so when your epidermis is vaporized by a CO2 laser, the body calls upon these stem cells to migrate upward and regrow the skin.
So if the medication has shrunk those glands to almost nothing, your skin has no reserve army to call upon.
The biological reserves are entirely depleted. The skin becomes so fragile during use that even routine waxing can tear it off.
Ouch.
If you ablate a face in that state, the skin simply will not heal. The microscopic columns of vaporized tissue will remain open, leading to massive infection and severe, irreversible scarring.
Which is why the British Association of Dermatologists guidelines demand a patient be completely off isotretinoin for a full 6 months before attempting any resurfacing, purely to allow those stem cell reservoirs to rebuild.
It's absolutely critical.
It all comes back to respecting the underlying mechanics of the biology. Looking at the entire journey of this procedure, we start by physically slicing the fibrous anchor ropes of scars with needles.
We induce controlled necrosis by pressing 95% acid into ice pick craters to force the floor to heal upwards.
We vaporize cellular water with 10,600 nanometer light, intentionally destroying the epidermis to force the dermis to generate new collagen.
And we endure a brutal multi-month crucible of recovery managing oozing bronzed skin by constantly slathering on inert Vaseline and dilute acetic acid to allow our cells to physically slide closed.
Not to mention tricking the biology of inflammation using Z-pattern algorithms and topical steroids to safely remodel the skin without triggering hyperpigmentation.
It is a remarkable aggressive synthesis of physics, chemistry, and human biology.
It really is. Whether you are seriously considering one of these intense clinical procedures, or you're just at home applying a gentle over-the-counter retinol cream before bed, Understanding this underlying mechanism, the reality that injury equals renewal, fundamentally changes how you view skincare.
It definitely shifts your perspective.
The line between a lasting permanent scar and a flawless renewed complexion is literally measured in fractions of a millimeter and a few degrees of heat.
It demands a profound respect for the regenerative capacity of human tissue.
It absolutely does. But examining the sheer violence required to achieve these results leaves me with a lingering thought. If our absolute most effective method for reversing aging, erasing damage, and achieving perfect skin is to inflict highly calculated, severe trauma on our own tissue,
Hmm.
if we have to force our biology into a desperate, panic-healing response just to look younger, what does that say about our biological limits? Are we eventually going to hit a wall where we can no longer just burn our way to youth? And if we do hit that wall, what could possibly replace the raw, restorative power of controlled destruction?